These are the figures from chapter 236 entitled Pediatric Craniopharyngiomas. My name is Todd Hankinson, and I'm a pediatric neurosurgeon at the University of Colorado School of Medicine and Children's Hospital, Colorado. Figure 1 of this chapter demonstrates the age distribution of both adamantinomatous and papillary craniopharyngioma. And this pattern has been demonstrated in multiple studies. What it demonstrates is that papillary craniopharyngioma, which is not the primary topic of this chapter, presents almost exclusively in an adult population. On the other hand, adamantinomatous craniopharyngioma has a well-established bimodal age distribution with a fairly large peak in childhood and then a second peak in middle adulthood. It is unknown at this time whether these tumors represent the same entity on a biological level. Figure 2 demonstrates the classic histopathology of adamantinomatous craniopharyngioma, and this will likely be critical to the derivation of novel therapies. These tumors are known for being highly heterogeneous. On hematoxylin and eosin staining, what one can identify are epithelial regions, both whorls and palisading epithelium. In addition, diagnostic characteristics include the existence of acellular or wet keratin, which is likely highly eosinophilic acellular squamous cells or sloughing, as well as calcification. The parenchyma adjacent to these tumors often appears highly gliotic, which can be seen in panel D. As we will discuss in the next figure, an upregulating mutation in beta-catenin is the only known genomic abnormality of this tumor. This is reflected in beta-catenin staining in panel C, which demonstrates positivity in a subset of the tumor cells, most notably in the epithelial whorls. Figure 3 is a demonstration of the Wnt beta-catenin pathway. This is a pathway that is upregulated in multiple different types of tumors and is known to harbor the only known genomic abnormality in adamantinomatous craniopharyngioma, which is an upregulating mutation in beta-catenin. This occurs because the beta-catenin protein is not able to be degraded normally by the destruction complex. As a result, beta-catenin can accumulate in the cytosol and ultimately translocate into the nucleus of the cells. This is best demonstrated in the epithelial whorls of the tumor. When beta-catenin is within the nucleus, it can serve as a transcription factor with regard to Wnt pathway genes, and this can lead to myriad cellular activities, including increased proliferation. The exact manner through which this mutation leads to pathogenic behavior in craniopharyngioma has not yet been elucidated. The following two figures demonstrate common imaging findings of adamantinomatous craniopharyngioma. Figure 4 demonstrates CT scan, and Figure 5 demonstrates MRI findings. These two imaging modalities are highly useful for both the diagnosis and management of these patients and serve complementary roles. Classic CT imaging findings include thin or coarse calcifications in or around the tumor. In this particular image, one can see thin calcifications in both the coronal and axial planes, which are the images on the bottom of this figure. These calcifications are uncommon in other pediatric cell or brain tumors. The other finding of importance on the CT scan is that there is often remodeling of the cellular region, and in this particular case, it can be seen on the sagittal image that there has been remodeling of the sphenoid sinus as well. Given the increased use of transnasal endoscopic surgery for the diagnosis and treatment of craniopharyngioma, CT scan also plays an important role in mapping out the paranasal sinus anatomy and in intraoperative navigation. MRI scan offers the highest degree of diagnostic detail with regard to craniopharyngioma. Tumors often have a contrast-enhancing solid portion as well as a cystic portion. The cystic portion can be small and clinically insignificant, or it can be quite extensive and represent the major difficulty with management of these patients. The images in this figure represent two different cases, one of which had an average size cystic component in combination with the solid contrast enhancing component, the other of which had a very extensive, highly cystic component, which caused significant mass effect and extended through multiple areas of the intracranial space. A combination of a solid and cystic suprasellar lesion with calcifications on CT scan is highly consistent with adamantinomatous craniopharyngioma when identified in the pediatric population. Figure 6 demonstrates both progression-free and overall survival based on the initial treatment strategy. Initial treatment has been a controversial topic with regard to pediatric craniopharyngioma. What is demonstrated in this figure, and has also been demonstrated in multiple studies, is that the combination of subtotal tumor resection with external beam radiation carries roughly the same rate of overall survival as well as progression-free survival as an approach that targets gross total resection. Importantly, subtotal resection without adjuvant radiation therapy carries a worse overall survival as well as a lower progression-free survival time.